Rami, you're clearly at a wonderful cancer center, the Moffitt Cancer Center, and as we think about particularly trying to care for these patients, trying to prevent infections, trying to treat active preventions, clearly a multidisciplinary approach can be key. Not only in your center, but even across centers. We try to involve a variety of people. Why don't you give us a sense of the sort of multidisciplinary team that might be involved with caring for these patients?
Absolutely. No, I think that's a key for the management, and Eli touched based on this that AML treatment so far has been really centralized into academic centers where there are leukemia services. There is definitely a learning curve or experience from the team. So in our place, our unit, the nurses are treating leukemia all the time. They are familiar with the signs of complications, the infection. When we get a new drug approved, we get education for all the team on that. So we have obviously our main team. That's the first team, the heme team. We always have the infectious disease colleagues hand to hand with us and those patients. Like in our place, every leukemia patient that's coming in is seen by the infection disease people. They follow them. We discuss the cases together. Sometimes we see them together. And they are really key in the management of patients during the intensive chemotherapy. We need their help tremendously at that point. We do have palliative team, pain service that also are on board with us. We get a dietitian and nutrition team to see those patients up front. Our colleagues in transplant sometimes will come early on when we identify those patients, because you could take advantage of the month where the patient's in the hospital to go for the HLA typing. We have a social worker that actually gets involved and see those patients. So I think there are so many people that work together on this, and I think it's a key, although we tend to think that heme malignancies are not multidisciplinary team, but in the setting of leukemia, there is really a huge effort that goes behind the scenes taking care of those patients.
I want to add to Rami, finally these patients, when we treat them, we induce them at our center. But they're going to stay for their life with us, correct? We want to give them the first course. Maybe second, they want to work with the community physicians in the local hospitals. So they have to go back and forth. And communication between referral physician and us is really crucial, because any of us we're dealing with severe problems because we're all experts and we have this approach in our hospitals. But for example, I give somebody decitabine and he can go home and he catch an infection. So what do I do at home? And then I get the call from the doctor. What do I do? Sometimes they don't want to do anything because they're scared. Maybe I've given them the drug, it caused liver problems. He will call me. I have your patient on ponatinib. Can I give him these kind of azoles? Yes or no? So we're establishing a network, like all of us in Houston, in Texas, or other areas, where we communicating our protocols, our standard of care for them. If they can apply them for somebody, that's fine. If there's a problem, we bring them back. Obviously, somebody on clinical trials, we bring them emergency to MD Anderson. Otherwise, we try to communicate and give advice to the infectious disease locally, to the community oncologists, to the GPs who are handling this daily stuff. Example, somebody on decitabine maintenance who goes home, had infection. What do I do? So they start with antibiotic antifungal therapy, and then we'll bring them back later on if they are not getting better.
Well, I think this has been a great discussion. You guys have really shared a tremendous amount of experience, wisdom, guidance, and clinical expertise. But this has really been a pleasure.
Thank you.
We've discussed a lot of information on the latest advances in treatment and supportive care for patients with AML. To close, I'd like to get final thoughts from each of the panelists. Dr. Bejar?
I think this is an exciting time for AML. We've had a long stretch of time where we didn't have new therapies to offer our patients, and now our pathobiological understanding of these disorders is coming to fruition. We're getting more therapies that look very promising on the horizon, and we have an entirely new avenue to explore with these immune therapies. I think that we're at a transition point for AML, and it's an exciting time to be in the field.
Dr. Jabbour?
I definitely echo Rafael's statement. A lot of excitement, new drugs. I still reiterate, we need to treat these patients in the hand of experts and privileged clinical trials.
Dr. Komrokji?
Yeah, I echo the comments. I think it's very exciting. I'm looking forward to the presentation today at the plenary session to hear the data on the new drug that hopefully will be approved, improve the outcome. I think it's always important to maximize the benefit of the current available therapies. We discussed a lot about the best supportive care, so fine-tuning that is very important. But I think in the coming few years, as we understand more the biology, we'll have more options for treatment, more for patients, targeted therapy. So this is really a very exciting time.
I would agree. I'm very excited and very hopeful. I think we realize that even in acute myeloid leukemia, you're really talking about, dozens and dozens of different phenotypes, subsets, individual variabilities, not only around the leukemic clone itself, but their own health, their predisposition to infection, their cardiac status, their comorbidities. It really is an incredibly complicated area. But I think we're making some really genuine strides, and there's really some exciting data that is really helping to move things forward. So on behalf of our panel, we thank you for joining us, and we hope that you have found this peer exchange discussion to be useful and informative. Thank you.